Assalamualaikum doctors. In this video I am discussing about the management of anaphylaxis history. So first we know that what is definition of anaphylaxis. It is a sudden onset of a systemic life-threatening hypersensitivity reaction. Okay, systemic life-threatening hypersensitivity reactions. Trigger may be food, drugs, insects, sting and latex. Involve one or more of the acute onset of illness like from a minute to several hours, involving skin and or mucosal tissue within one of the following: respiratory compromise, reduce the blood pressure or symptoms of in-organ dysfunction, more than or equal to of the following after exposure to a likely allergen, from minutes to several hours, like skin or mucosal involvement, respiratory compromise, reduce the blood pressure, persistent gastrointestinal symptoms. Reduce the blood pressure after exposure to known allergen from minute to several hours. Infants and children, low systolic blood pressure according to age-related values or decrease in 30% of systolic pressure. Teenagers, that is systolic pressure less than 90 or decrease more than 30% of baseline. So this is anaphylaxis definition. So anaphylaxis patient come in front of us. How can we manage the child? Immediate treatment. Remember, management of anaphylaxis algorithm. First, remove the allergen if possible. Call for help and adrenaline I am giving. So remove the allergen, call for help and adrenaline I am. Give in mid outer thigh. Technique is very important to know. Auto injector may be used. Dose by age or 10 microgram per kg, 10 microgram per kg, 1 in 1000 strength, 0.01 ml per kg in 1 in 1000, 0.01 ml per kg 1 in 1000, maximum 0.5 ml equal 0.5 milligram. Less than 6 year we give 150 mcg, 6 to 12 year we are giving 300 mcg, and more than 12 year we are giving 500 mcg. Do not give adrenaline for widespread facial or peripheral edema and rash in the absence of other systemic symptoms. So without anaphylaxis, we will not give adrenaline. Then ABC approach, provide BLS as needed, basic life support. Like facial edema should prompt careful review of airway. If airway edema, call an anesthetist for potential difficult airway intubation. If not responding to adrenaline IM, give nebulized adrenaline 1 in 1000, 1 mg per ml, 400 microgram per kg, maximum 5 mg. Test shock with sodium chloride 0.9%, 20 ml per kg bolus. So ABC basic life support, these are we maintain. If shock, we give the 20 ml per kg normal saline bolus. Sodium chloride 0.9%. Monitor the saturation, blood pressure and ECG. This is my immediate management. So I have given the IM adrenaline outer thigh. If no response after 5 minutes, repeat the adrenaline IM. If no response after 5 minutes, to second dose of IM, give IV. So first 2 dose we are giving IM. The third dose after 5 minutes we are giving IV. Give IV infusion 1 microgram per kg, that is 0.01 ml per kg in 1 in 10,000. Maximum 50 microgram in sodium chloride 0.9%, 10 to 20 ml infused slowly over 1 minute. So when we give the IV adrenaline, we give the 0.9% 20 ml per kg sodium chloride with that. Do not give adrenaline intravascularly except in cardiorespiratory arrest or in resistant shock, not response to 2 IM doses. There is some subsequent management. Admit for minimum of 6 hours to detect potential biphasic reactions and usually for 24 hours, especially in the following situations. So there is subsequent management. Immediate after that, admit when we do the admissions. Like severe reactions with slow onset caused by idiopathic anaphylaxis. Reaction is individual with severe asthma or with a severe asthmatic component. Reactions with possibility of continuing absorption of allergen. Reaction with possibility of continuing absorption of allergen. Then patient with previous history of biphasic reactions. Patient presenting in evening or at night, or those who may not be able to respond to any deterioration. Patient in areas where access to emergency care is difficult. So slowly reaction occur, severe reaction occur. Home is far away, at night time presentation, evening or night, then continuously the biphasic reactions. These are asthma patient. Then we will monitor the saturations, ECG and non-invasive blood pressure as a minimum. Sample serum for mast cell tip test. What investigation we do anaphylaxis? Mast cell tip test. Remember, mast cell tip test. At the following time, if clinical diagnosis of anaphylaxis uncertain and reaction thought to be secondary to venom, drug or idiopathic. Immediate after reaction, 1 to 2 hours after symptoms started when level peak, more than 24 hours after exposure or in convalescence for baseline. So mast cell tip test immediately new 1 to 2 hours after and 24 hours after. If patient presenting with late, take as many of these samples as time since presentation allows. Now discharge and follow-up plan. There is a discharge and follow-up plan. First of all, discuss with the consultant pediatrician before discharge. I will talk with my consultant. Give the following to the patient or their patient and the carrier. I will give some advice. First of all, information about the anaphylaxis, including signs and symptoms of anaphylactic reaction. Information about the risk of biphasic reaction. Information on what to do if anaphylactic reaction occurs. Use adrenaline injector and call emergency services. Demonstration of the correct use of adrenaline injection and when to use it. Advice about how to avoid suspected triggers if known. Information about the needs for referral to a specialist allergy service and referral process. Information about patient support group, bracelet. Then discharge with an emergency plan, including to adrenaline pen auto-injector after appropriate training. If still symptomatic, give oral antihistamine and steroid for up to 3 days. Refer as outpatient to consultant pediatrician with an interest in allergy. So you understand who discharge and follow-up. First talk with the senior, my consultant pediatrician. Give information about anaphylaxis, its signs and symptoms. Give a diary. Try to avoid the triggers. Before eating, they see the label. We will give them how can you use the EpiPen. It is video recording, information material, everything. We will give them knowledge. We will give them 2 EpiPen injections. We give them, if there is some allergic feature present, we give 3 days of steroid and antihistamine. And also for follow-up outdoor patient and what to do in emergency, we will tell them. Information about the risk of biphasic reactions. These are the advice and follow-up we give. Thank you.